My name is Guanbo Peng, and I'm a neurologist from the University Medical Center Hamburg-Eppendorf, Germany. In this video, I would like to talk about paroxysmal hemicrania and hemicrania continua. And let me start with the story of the patient. Mr. N is 48 years old, and he has developed a recurrent headache since the year of 2013. The headache in the beginning was only 2 attacks per week, with an attack duration from 10 to 15 minutes. The pain was 8 to 9 from 10 in the VAS scale, pulsatile, located in the right retroorbital region, with radiation to the right hemicranium. The pain was accompanied with unilateral cranial autonomic symptoms, including lacrimation, rarely nasal congestion or rhinorrhea, and it was usually accompanied with restlessness. The attack frequency increased over the years. Now it's 3 to 5 attacks per day, more often in the afternoon or evening. There is some seasonal differences, but the differences is not large. Mr. N visited several clinics and has been diagnosed with cluster headache. He has tried intranasal zomitriptan and oxygen treatment, but both of them are without obvious effects. A therapeutic trial of verapamil did not reduce the headache frequency either. There was some improvement after NSAID or analgesic combination products, but the effect was not ideal. The patient was referred to our headache clinic 6 years after the initial symptom developed. In this case, Mr. N fulfills the diagnostic criteria of paroxysmal hemicrania. Paroxysmal hemicrania is featured by strict unilateral headache, accompanied by either cranial autonomic symptoms such as conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead or facial sweating, miosis, ptosis, or a sense of restlessness or agitation. One of the prominent features of paroxysmal hemicrania is the absolute response to adequate dosage of indomethacin treatment. Therefore, we started a therapeutic trial of indomethacin with an initial dosage of 25 mg 3 times a day. The patient became nearly symptom-free since the first day of the therapeutic trial. In the meantime, the patient gradually noticed mild GI upset after the use of indomethacin. Due to the GI side effect, we suggest a switch to the COX-2 inhibitor, but the efficacy of the COX-2 inhibitor must be first confirmed before the switch. Alternatively, we discuss with the patient the possibility of adding a second medication such as gabapentin or topiramate, and gradually taper the dosage of indomethacin. This is a classic case of paroxysmal hemicrania and suggests the importance to raise the clinical awareness of it and the potential clinical treatment challenges. Paroxysmal crania is actually rare. The actual prevalence is not known, but under estimation is approximately 10 to 35% of the cluster headache, and men and women are equally affected. The mean age of onset is approximately 40 years old. Paroxysmal hemicrania belongs to the group of primary headache disorder called trigeminal autonomic cephalalgia, TACs. And these group of headache disorders share similar characteristics, including unilateral headache and cranial autonomic symptoms. But they differ in attack duration. For example, short-lasting unilateral neuralgic headache with conjunctival injection and tearing, SONT, or the short-lasting unilateral neuralgic headache with autonomic features, SUNA. Both of them, they have the shortest attack duration, only up to 10 minutes. And paroxysmal hemicrania is in the middle with a duration of 2 to 30 minutes, longer than SONT, but still shorter than cluster headache. As you can see here, these headache durations do have some overlap. Therefore, for example, when the attack duration of 20 minutes it would be difficult to classify the headache solely on the headache duration. And in this spectrum, there's also an exception here. That is hemicrania continua. Hemicrania continua shares similar characteristics with paroxysmal hemicrania, but the headache is continuous. Here are the diagnostic criteria for hemicrania continua. Basically, the headache features are nearly identical to paroxysmal hemicrania, except that the pain is continuous and present for more than 3 months. There are very few diagnosis criteria of ISHD3 that incorporates treatment response as a criterion. Both paroxysmal hemicrania and hemicrania continua belong to this group of indomethacin-responsive headaches. In order to determine a response or a lack of response to indomethacin, a drug trial of a dosage up to 150 mg, and in some cases 225 mg per day is necessary. Alternatively, piroxicam and celecoxib are reasonable options for acute treatment when there is contraindication to indomethacin or the patient could not tolerate it. But the trickier question in treating PH-HC is the prolonged use of medication. One needs to consider the gastrointestinal and other side effects. There are some smaller clinical trials out there using celecoxib, topiramate, or gabapentin with moderate effects. Let me summarize the short video here. With proper clinical awareness, the treatment response of paroxysmal hemicrania or hemicrania continua can be dramatic. Of course, the challenge remains with prolonged therapy. One needs to balance the efficacy and side effect of the medication. And definitely more studies are needed on the therapeutic options in treatment of paroxysmal hemicrania and hemicrania continua. My name is Pen from the University Medical Center Hamburg-Eppendorf, Germany, and thank you for your attention.